series. So the food is arriving now. Please feel free to partake quietly over the course of the seminar. And I want to just say that I'm pleased to welcome Dr. from Harvard to come speak with us today. We are endeavoring to have seminar speakers here at the ISPH seminar series that have topics relevant to implementation science. When I met Kelli at an NIH study section, I don't know, several months ago, I think we both got placed in conflict or something, and we had a chance to talk about like what we're each doing. And I learned about this project and a recently awarded K that she got to look at linkage to HIV care in the Nakivale settlement in Uganda. And I know that she's very early on in the work in her aims in this K, and we'll be working towards developing some kind of linkage intervention to address HIV linkage to care, and this is something we do a lot of here. And not to mention, I think a lot of the refugees in your settlement come from some of the places where we work in Burundi and Rwanda. So thank you for coming down to talk with us about your K research project, and we're looking forward to hearing more. Welcome.
Well, thank you, and I am really looking forward to having the time to meet with you guys. I know it's not really a research in progress meeting, but I think at this stage for me, everything's a research in progress meeting. So I hope that you guys will put your hats on, and if you have a good idea, talk to me. Let's brainstorm, let's collaborate. I wanted to just start by telling you guys where I'm from and my background. So I live in Boston now, and I'm at Harvard, and I've been there for 10 years. I'm actually a West Coaster. I'm from Portland, Oregon, and I went to University of Oregon, Oregon Health and Science University. And then I trained in emergency medicine. I'm a physician at UCLA, all of you in Los Angeles. And then I came out to Harvard, drawn by the School of Public Health, where I did my master's in public health 10 years ago. And I've stayed on there as faculty, doing both clinical medicine as well as research. So today I'm going to talk with you guys about, first of all, just give you a brief background about HIV in sub-Saharan Africa, in particular among refugees, what we know and really what we don't know. Share with you about my study site in Nakivale Refugee Settlement, talk to you about my prior research, my current research, and then just finish with my thoughts now on designing an HIV linkage intervention specific for the refugee settlement. So first of all, background on HIV and refugees in sub-Saharan Africa. There are 37 million people in the world with HIV. But amazingly, 26 million of them, which is about 70%, are in sub-Saharan Africa. Not surprisingly, in this place where there is a lot of conflict and a lot of development going on, we have 65 million people displaced globally, and more than 18 million of those people are in sub-Saharan Africa. But the numbers that we don't have are how many people are displaced that are living with HIV. So I think this is a really important population and one that merits its own dedicated research and its own kind of body of focus because refugees face unique hardships. They sometimes face unique hardships accessing basic needs. They sometimes have disrupted networks, limited livelihood opportunities. They can face threats to their own security. And globally, the average length of displacement for a refugee is 17 years. So it's not always the acute crisis that we're thinking about. It's important to think of the long term as well. Hardships might increase the vulnerability to HIV infection, though this is really a complicated, complex thought process, as some of you probably have thought about. But some refugees have more frequent sexual violence encounters. Some have participated in transactional sex. Some face difficulty accessing condoms. And for some refugees, accessing treatment for sexually transmitted infections and other things is difficult. Now, I started that sentence with the fact that it's actually really complex, and you can't just say that refugees are at higher risk for HIV or have higher prevalence, because actually they don't always. So one of my mentors, Paul Spiegel, is at Hopkins, and he is an expert in HIV and refugees. And he has a nice publication that talks about how HIV risk factors in conflict zones and camps is actually really complex. And the most important thing is, first of all, the prevalence in the area of origin of the refugees or the displaced population, and then the prevalence in the host population and the mixing of those two. And then there's a host of things that increase the risk of HIV transmission and some that decrease. In terms of increased risk, some have behavior changes in the setting of conflict. Some face gender-based violence, participate in transactional sex, and for some, there's reduction in resources in terms of condoms, HIV services. On the other hand, in some refugee settlements or camps, there's actually reduced mobility for the people living there and potentially, therefore, decreased transmission, reduced accessibility by higher prevalence populations, like in the urban areas, and sometimes increased resources, surprisingly. Sometimes in the settlement, the health clinic is well established, services are going well, and in some places, you'll find that the refugees are actually better off than the surrounding host population. So it's complex. And it's also political. So it's important to note that some people spend their career actually making these statements and saying refugees do not have higher prevalence and refugees are not higher risk, because there's also an ask of host countries to take in refugees and to have them and host them. And so this conversation is complex, as are the findings of all research and all publications. So this is where I want to tell you about where I've been doing research. I started in Nakivale Refugee Settlement. So Nakivale Refugee Settlement was established in the 1960s. It's been there a long time. It's big, 71 square miles. And at the time of most of the research that I'm going to tell you about today, there were 68,000 refugees, but that number is now over 100,000. And refugees come from at least 11 countries, 52% from the Democratic Republic of the Congo, 17% from Somalia, 15% Burundi, 15% Rwanda, and then a little bit other. In Nakivale, refugees are housed in zones, in general, by country of origin. So people arrive pretty much by the busload, and they'll bring them to an area, and they're given plots of land on which to raise food and sometimes grow animals. There's 4 health clinics in Nakivale, the main health center, and 3 satellite clinics that you see in this map here. And all of them offer free HIV testing and free antiretroviral therapy. Money is given from UNHCR to the Ugandan Ministry of Health, and services are provided by the Ministry of Health in Uganda. And actually through health contracts to organizations. Currently, the organization with the contract is Medical Teams International. So the HIV prevalence from refugees' countries of origin really range from 0.5 to 6.1, and according to Ugandan behavioral surveillance surveys, the prevalence in the surrounding region in Uganda is about 7.3%. So over the last number of years, specifically since 2009, I've been working on collaborating with local partners to do evidence-based research with the goal of evaluating existing services and enhancing access to HIV testing and care, both for Ugandan nationals and for refugees living in the settlement. And when I first started my research there, the health contract was actually with GIZ, a governmental organization out of Germany. And as I said, now Medical Teams International has the health contract. And all my work is done approved by and in collaboration with the United Nations High Commissioner for Refugees as well. Here's a picture of most of my team, my project manager and 4 research assistants. I've always had a team of all refugees, half of whom live in the settlement and half of whom come there, live in the cities now, but come to the settlement. This is really helpful because all my research is in many languages, and to actually interact with the local population, my consent forms are in 4 languages. It's pretty complicated. So it's both acceptable to the participants as well as functional. I also have always had a community advisory board that I meet with 3 or 4 times a year, drawn from various country groups, and I try to ask them ahead of time, this is what we're thinking about for the next study. What do you think? Does it sound crazy? Would it be acceptable? What might be a better way to do it? And just try to think ahead with them before jumping too far into the research. So now I want to give you just some background about what I've done so far. My work in Nakivale started with a qualitative study in 2011. And I'll start by saying it's so much easier if you have a mentor that you can build on their study site. But I didn't have that, and my real passion was to do research in a refugee settlement among refugees. So part of my reason for having my very first study be this qualitative study was I wanted to generate, it was hypothesis generating. I wanted to learn what were the issues here and from the refugees. So my goal was to identify and describe barriers and facilitators to HIV testing and adherence to HIV medications for HIV-infected refugees in Nakivale. And I did this with 77 qualitative interviews, both with clients and staff. And this is a picture that shares with you what I found from this study. I found that the basic survival needs for the refugees, food, safety, shelter, those were their daily priorities. And in order for HIV testing to happen, something had to trump those priorities. And normally it didn't. But there were some instances, specific circumstances, that led to priority shifting. And those are demonstrated on the outside of the circle. One example is a reduction in barriers. For instance, if the clinic did a mobile testing unit and all of a sudden there it was right in front of them, some of them would say, fine, I'll test today. Another example was shifting priorities. A lot of people said, well, I had to go to the field every day and grow food, but when all of a sudden I was so weak that I couldn't go do that, then I had to do something else for that day, and that was when I went and tested. And a final thing that the participant spoke about was the survival burden. Basically, some years even, there's poor rainfall or poor growth of crops. In those times, everything is hard, and there's less energy and time to do anything else besides from figure out how to get water or how to get food. However, there's other examples of seasons where everything is plentiful. There's food, there's water, people are healthier, and in those times there's more space and freedom to take care of more longer-term things and less focus on the daily priorities. So this really had me thinking in terms of HIV testing and designing interventions. I was going to have to think of a way that it would fit into the survival priorities of refugees and make it easier for them to basically access testing. And that led me to my 2013 routine clinic-based HIV testing study that I did at the Main Health Center in Nakivale. This was funded by the Center for AIDS Research at Harvard. The first objective was to implement and evaluate routine HIV testing at this Main Health Center and compare it to their standard care. And the second objective was to look at correlates of HIV infection of those tested during routine clinic testing. The eligibility criteria was adults that basically were able to provide informed consent. As I said before, it's a complex setting, so we always have 4 languages, English, Kinyarwanda, Kiswahili, and Runyankore, and so far we've never had anyone not participate because of a language barrier that we know of. We offer surveys. For this study, we conducted surveys and HIV tests in semi-permanent tents that we constructed near the outpatient department. And we basically provided surveys orally and entered them directly into computers while we did the rapid HIV tests and then prior to giving the client their results. And the surveys included demographics, socioeconomic information, and as I said, everything was entered directly, trying to protect that information. Here's some pictures. The top left is the main HIV waiting area. It's the outpatient department, not HIV. So they're just waiting to see a doctor. And what we did was, top right, you see one of my research assistants standing in front of the crowd saying, oh, we know you're here to see a clinician today. You won't lose your place in line, but if you'd like to come over to these semi-permanent tents that we've just erected, we would be happy to test you for HIV. And while I'm talking about HIV, let me tell you a little bit about it. This is what it is. This is how you could prevent transmission and just some information sharing. And then they would, as I said, sit there, do the HIV test while it sat and processed. They would do the survey and gather information. At the end of the time, they shared the results with the participant right then, which also was very unique in the setting because in the standard of care, people would go see the clinician, sometimes with the goal of testing, sometimes for something else. The clinician would either choose to do the test or not, send them with a referral slip to the lab. The lab would run the test. A couple hours later, the results would be ready. The person might or might not be there to get the results. You've heard that story before. So here are some findings that we had from that study. On the standard of care, which is in the first row, in outpatient department, this was a shorter period of time, 40 days, there were about 3,000 people that came to the clinic, of whom 209 were tested, which was 6.7%, with a prevalence of 3.3%, and a number of mean cases identified per week of 0.9. And just by making the announcements and offering testing in the tent, during this longer period of time where 15,000 people came to the outpatient department, 4,207 were tested, which was 21% more or less, with a prevalence of 4.5% and 5.6 cases identified per week. Of note, there isn't a difference in the HIV prevalence between those two weeks in terms of statistically significant. But we did find that just with this intervention, we were able to find 5 people per week rather than 1. So this was important information. And if you can remember, the second objective for this study was to look at correlates of HIV infection in this setting. And so we continued the routine testing infrastructure. By the time we tested 7,766 people, we did this analysis. Of those tested, 52% were female and 69% were refugee. Of those tested, though, that were HIV positive, we found 330 to be positive, 4%. 63% were female, so slightly higher. Only 34% were refugees. And so the HIV prevalence among just the refugees was 2%, and among the nationals was 9%. So we found, same data set, that there was an equally increased likelihood of HIV infection for those that were female, for those that were divorced, separated, or widowed, and for those that lived more than 1 hour from clinic. Conversely, there was a decreased likelihood of HIV infection for refugees, for those that reported to be single, and for those that had previously tested. And perhaps most notably is just this number that refugees are a quarter as likely as Uganda nationals to be found HIV infected. The takeaway from this for us, we don't feel like we've elucidated all of the factors by any means, but the takeaway is that we want to understand more about high-risk populations, because if we do this, we can better target future interventions in this setting. And that's really important in this resource-limited area. In 2013, I did a home-based HIV testing study in the same vein, trying to think of what are ways that I can bring HIV testing to this population, and will it work, and is it acceptable, or is this not acceptable in the setting? So the goal was to assess feasibility and acceptability of going to homes in the settlement. We visited homes up to 3 times, different days of the week, different times of day, in 3 distinct zones, with the goal to assess the feasibility, which we called the proportion of eligible participants found at home, and the acceptability, the proportion of those at home that tested for HIV. So here in Table 1, I'll show you the results from this study. Of 319 households that we visited, we found 566 individuals living in those households. At visit 1, 353 people were home. That was 62% of all of them. 272 tested, and there were 6 that were positive. Visit 2, 127 were home, 93 tested, and 1 was positive. And visit 3, we found there was less of the remaining people home, and there were no positives. But in conclusion, we found that it really was feasible. We found 90% of those that were eligible by going 3 times, and 75% of those that were at home were willing to test. That was important. I have not yet done a follow-up study for this, although I would love to do a randomized cluster sampling just to get a better idea of prevalence of HIV in this setting. It's a little bit tricky because of the next study, which is, I looked at the HIV Cascade of Care in Nakivale, and the goal was to evaluate the HIV care continuum, assess the proportion of newly diagnosed patients who linked to HIV clinic, and then look at those who had a CD4, find out those who were started on antiretroviral therapy, and those who were who were eligible, who started on antiretroviral therapy. So this is a picture of that. You guys have heard of the Care Continuum in other areas, sub-Saharan Africa. This is just trying to figure out what does it look like in this setting. And of 6,850 tested and 276 HIV infected, only 54% showed up at any of the 4 clinics in the settlement. And of those, 20% had a CD4 test, and this was back when a lot of the ART decision-making was based on their CD4. 8% of those were ART eligible based on the numbers at the time, and 6% were started on ART. And this wasn't even fancy enough to have viral loads or you know, to talk about suppression. Wasn't there yet. But this is, this kind of stopped me in my tracks, because here I was like, HIV testing, home-based testing, routine testing, and then I was like, whoa, only half of the people that I'm finding that have HIV are actually going to clinic and getting free medications. So I took a step back and trying to figure out linkage in this setting. This demonstrates here that we did look at a number of predictors trying to figure out, can we figure out who's linking? Is it by gender? Is it by refugee status? Is it their relationship status? And all of the factors here were not statistically significant and did not tell me about who was linking and who was not linking within 90 days of a new diagnosis. So I had made some steps forward to figuring out HIV testing in this setting, but when it came to figuring out linkage, I'm kind of stuck there, which leads me to my current research. In 2014, I did an enhanced communication linkage intervention study, developed, pilot, and evaluated an enhanced communication intervention using text messages and phone calls for HIV-infected clients diagnosed through routine clinic-based testing. So the standard of care before was we would test them, tell them they had HIV, and we would encourage them to go to clinic, because that was also what had happened at the lab or what had happened with the clinician. And what we found, as I told you before, in the Care Continuum study was that only 54% went. So with this study, the design was we would test them, and then if they were willing and eligible, we would send them message reminders, and we would call them and send them phone call reminders. So that during this study period of enrollment, we found 209 HIV-positive people, some of whom were eligible to participate, some of whom weren't. And we are still working on this analysis. I will say it was much less than perfect, and I learned a lot from this study, and my future studies are going to be a lot cleaner. Part of the problem was, and this is part of the difficulty in this setting, I really wanted to give cell phones to everyone that was willing to participate, because that would have been better, because then everyone could participate if they wanted to. But UNHCR really didn't want me to, because that wasn't sustainable. And one thing that I agreed with was it would be potentially an identifier. Like if someone was not planning to disclose their status and all of a sudden they had a new cell phone, I mean, how do you explain that? So there wasn't really a good workaround there. But it ended up really messing up who could enroll in my study, because if you think about who has a phone and who doesn't, that's like a big bias. So that analysis is still in progress, but probably the discussion of the paper is going to be mostly about what I learned, unfortunately. A few other things that I learned from this study is that while one person says because part of the eligibility is, do you have a cell phone? And a lot of people are like, oh yeah, I have a cell phone, I have a cell phone. But then somebody else answers it, and you're like, wait a second, Jane said that was her cell phone, and it turns out they share cell phones. Like a lot of people share cell phones in this setting. The other thing is, as we all know, in this setting, super complex, there is limited electricity, and one thing people do is they turn their phones off. So you're not going to get phone calls, and you're not going to get text messages if your phone's sitting in your pocket off, and that is also tough. And finally, I knew that this population had a low literacy rate, but I did not know that it was going to be as low as it was, because part of what we did when we were enrolling people was ask, could we send you text messages? And they could still participate if they couldn't receive the text message, because we could call them, but at least half said they would not be able to read the text messages. So that was good to know also. So now I'm moving on to trying to take all that I've learned so far and all of your collective power to try to figure out how to design the perfect HIV linkage intervention in this setting. And I say specific for the refugee setting because I do think there has to be ways to capitalize on the structure of the refugee settlement environment. There's food distributions, there's vaccination campaigns, they live in zones. But there's also other limitations. There's no bus system. There's decreased livelihood. I mean, there really are. It's really hard to earn a living, and so a lot of people are growing food. So there's some resources like phones that are just, even though people say they have them, it's not the same as Kampala and Mbarara. It's just different than other places in Uganda. So as far as what I am working on from my K, the aim one is to use a qualitative approach to really get into understanding the barriers to care, to linking to care for refugees and ways around them. Aim two is then to take a quantitative approach, basically learning from the qualitative survey, and to use validated survey instruments to try to learn more about that. Like if they say, if I understand from qualitative survey that there's some depression or a lot of PTSD in the family, then doing some PTSD scores, things like that to really quantify that. And also keep in mind this is all structured on top of looking at linkage, so I'll be able to give that survey and then 90 days later see if that person ended up going to clinic or not. And so aim three is where we are here in this discussion, in this brainstorming, which is to develop, implement, and evaluate some type of ideal linkage intervention for this setting, which really is complex. And I'm trying to thinking about it from a social ecologic model framework. So it's not just the individual, right? I put some examples here, though this is by no means exhaustive. In the individual, it might be mental health problems. It could be substance abuse, although there doesn't seem to be a ton of that in the settlement. Self-efficacy might play a role. Definitely, I know competing needs plays a role. In terms of the social environment, HIV stigma is very big. A lot of people in our qualitative interviews are not disclosing their status, or they're telling maybe one person. Social support might play a role. It might be the population demographics. It might differ between country groups. So far, while every analysis has always looked by country group, I've never actually been able to find the numbers to make a difference between country groups aside from Ugandan nationals and refugees. It might be migration practices. The physical environment, I'm interested in the location of where people live compared to where the health clinic is. What barriers are there? Is there a river? Is there a soccer field? What the freshwater locations are that they have to walk to, because they do walk to get their water. Some of them walk an hour a day, some of them walk 2 hours. How does that play in? The food distribution sites, as well as the rations that they're eligible for, because it changes. When they first show up, they get some certain amount of food rations. After a year, some of them go to about half and then quarter, so it decreases over time. It's not always the same. They're expected to provide for themselves. And then in terms of policies and regulations, food distribution policies, land use policies, security of the environment, I'm trying to basically look at all of these to see what might play in or what might be a good idea. And so building right now, as far as aim one, what I'm working on, as I said, it's on top of the routine HIV testing infrastructure. I'm still enrolling participants as I'm testing them for HIV. Now, instead of just being at Nakivale Health Center, we're also at Juru Satellite Clinic and Chibengo Satellite Clinic. And 90 days after testing, we're inviting people back for their interviews, doing semi-structured interviews based on the social ecologic model framework to assess the participants' experiences. One difficult thing that we're experiencing here, which also is not surprising, is it's really hard to get people to come and interview that didn't link to care. That's something that's been shown elsewhere. We're trying to work around it, but it's definitely a barrier that we're struggling with as well.
Are you finding them, or are you not finding them?
I don't know. So there's a lot of different answers to that. We have phone numbers, and we call them, and my staff say that a lot of times they say it's not them. They say, I don't know, you're trying to reach John, this isn't his number, or they say it's his sister's phone, but my staff a lot of times think that they do find them, that they're just denying that it's the same person. So that's hard. And I even actually, for the first time, got approval from UNHCR and everybody else to offer an incentive to come back and interview. So it definitely covers food and transport for that whole day for sure, if not like a half day's worth of construction labor if you had a construction job. So I thought that would be a good draw, but I don't know. So actually right now I'm implementing something more for my staff that's even more like, it's like a talk sheet, so just to make sure that we're really touching on all the fine points, like, where are you, Kampala? We'll come to Kampala, just to make sure that they're not missing any of the opportunities that we could have to find people. So this is where I ask you guys just to think with me for a second, as far as ideas, how to enhance linkage to care in this refugee settlement context, thoughts on expanding routine HIV testing or home-based testing. I do have the ability to go to other places in Uganda through my contacts with Medical Teams International, so I'm excited about thinking about expanding routine testing elsewhere in the country, although linkage is important. And then while all my work so far has focused on HIV, I'm really also thinking broadly about different ideas that are important areas for refugee health moving forward. And that's where, if you have specific ideas, I definitely invite the discussion and brainstorming, collaboration. And I'm going to open it up for discussion, but I just wanted to share with you this list of important people that are collaborators and mentors and people both in Uganda and also in the USA. And I invite you all to be in touch right now as well as later, if you think of anything. So I really thank you for the opportunity to come here and talk to you guys, and want to open it up for any questions. Absolutely. Yes, please. Yeah, that's a great question. I have always and will continue to always involve Ugandan nationals. The health clinics serve nationals as well as refugees. There's no distinction. I mean, we ask them who they are, and they ask them as well, but they're welcome to come and participate in all the health services and in all of our research activities. And we're always gathering that data and trying to see exactly what you said, which is there a difference, or is it just this area of Uganda where they're living, or not? The populations are different, but I'm not sure we have all the answers there. I will say that the Ugandan nationals are not supposed to live in the refugee settlement, but some of them do, and some of them were probably living there well before it was a refugee settlement, so they feel like it is their land, and maybe it is their land. But as far as the area goes, it's actually kind of blocked off for refugees, and when they find that it's a national living there, they'll like cut down their matoke and move their belongings one day, and all of a sudden they're like moved along. So I think the Ugandan nationals that are accessing services there might be a unique population as well. Some of them might be coming because of stigma that they faced where they were living. Some of them, I think, actually drive from Mbarara to get tested in Nakivale, which is like the nearest city, an hour and a half away, to get tested there and even get services there because they're just more anonymous. So you probably have a higher risk population of Ugandans than you would otherwise. Yes.
You generated that cascade. Do you have a sense or any for areas that are accessing care, other clinics outside of the port?
No. I wish I did.
And then that relates to my other question about what was the time period for that, and what's the mobility? You mentioned like population migration.
Mm-hmm.
How often do we think it's moving to the areas that study?
Great questions, and I'm trying to figure some of that out now in my K. At the time, I didn't have any mechanism set up for a good follow-up to try to figure out, did they die? Did they move back to Rwanda? So I don't have that, but I just know that it's a population that isn't very mobile, just from what I've learned from the setting, and a lot like in my routine testing that most people have been there for 5 years, the people that are testing. So it's uncommon, but it's not uncommon for people to leave temporarily. And so it's possible that they just dropped off the radar for 2 to 3 months because they got a construction job in the north and then they were coming back. So that's what I'm trying to dig deeper into now. It was a 90-day, as far as linkage, it was 90 days. And I'm trying to really dive into that. It's tricky. And another thing that research-wise I find very difficult is what I'm willing to do research-wise is less than, I'm ethically less than, I'm not willing to like go to people's houses, and I just feel like it's not what they gave me permission for. But actually some of the health staff are like, what do you mean you have a new diagnosis and you haven't like hunted them down? Because some of the, in Uganda, some of the staff will be very aggressive, and it's actually acceptable to really find your patients. I would never be able to get it past a U.S. IRB, of course, or nor that what I necessarily want to, but I do feel a little bit bad that I'm not able to offer them these great services sometimes when I lose them. So there's like that research service delivery ethical problem that comes up.
Well, I mean, here in New York, the health department considers it part of their mission. That when people drop out of care and they'll fine, they'll try. I don't think that it's the researcher's job unless you get their consent.
Right.
But from whoever the stakeholders are for rolling communicable diseases, refugee camps,
Jurisdiction. Yeah. And at first, actually, now we're completely data sharing. I mean, they have all of my data as far as who I've found. At first, we were more separate as I was learning and like figuring it out and working my way in. At first, I had registers that I was submitting to the Ministry of Health. They had their clinic stuff, and it wasn't integrated. Now we're integrated so that they could actually do that. But that's always made. I did actually at one point submit an IRB amendment and add to my consent form, your data will be shared with the clinic staff. They might do their normal processes, like come and find you. Because I felt really like people should hear that. I mean, that's what they were doing. So I felt like I had to be very explicit about it, which I think is probably the right approach. Yeah. Yeah, I mean, I think it was earlier in my like research career. I don't think I had a really great rationale, except for that it seemed like it was working in a lot of other areas in sub-Saharan Africa. And I was curious if it would work among the refugee population. But I didn't really, it wasn't based on a theoretic model or anything brilliant, that's for sure. It was more just like, it seemed like it was working even in Uganda and Kampala and in Mbarara. And I had mentors that were working outside of refugee environments where it seemed like they were having success. But yeah.
Yeah, so I guess that's where I would think about brainstorming maybe.
Yeah, please.
I think what we heard a lot of was communication and experiences can catch a lot of load, right? So the people will be anger, that's sort of the loading. So it's like a lot of it, you kind of like laid out a really interesting map, socio-ecological framework as to why there were other. Some of what I think really has hung out very clearly, because I haven't done that here, not in heavy detail, but is very ingrained about what it means to have HIV and to have HIV. So while it might be one city that might have to do with, what communities are accepted into or pushed out of, might be something else about status
Mm. Mm-hmm.
Maybe it would be something about
Oh, that's a good idea.
or experiences that are structured.
It's a great idea. That's a really great idea. I also. Mm-hmm.
Study all the linkages and then you stick in donuts. Maybe part of a spectrum
Mm-hmm.
barriers.
I do have one other publication that's not out yet that's submitted that talks about it's people's experiences of taking antiretroviral therapies from my very 2011 data set. But they talk. I felt like there was a recurring theme about people on antiretroviral therapy feeling linked to clinic, like almost tied to clinic, chained to clinic, in terms of. I felt like it wasn't like enough to conclude for sure, but it seemed like it was prohibiting their durable solution. Like they weren't leaving the refugee settlement because they were. So it might be that people don't want to have that link because they're trying to get somewhere else. So there might be a place like in terms of migration or resettlement or repatriation or integration that maybe they're trying to go somewhere in their mind, even if it's going to take a decade, and that they're not looking for putting down roots. Oh, I haven't collected that granular data, but definitely people have large networks of families. Some people have been almost like born there and continued, and some people came by themselves just last year from the Congo and lost everybody, and they're there with maybe one child, and they had a spouse and a huge family before. So everyone has a different story, but there are all those stories there, and it would be interesting to see how that links.
I can see if you had fewer people in the camp and more people somewhere else, that's likely to want to,
Uh-huh.
you want to be.
Yeah. Yeah, it's really.
I mean, I can definitely see that as being an issue because some of the interviews that we did, I did a study in Nakivale, and some of the just talking with well, a lot of them didn't even went to English class and job training because they think they're leaving in next month. Like they really do, and this is 7 years or 2 years you've been here, and it's like
Always been leaving their job.
yeah, exactly. And so I know that there's that not wanting to lay down roots, and I don't know if that necessarily would also apply to the idea of getting. But the other thing too, does UNHCR facilitate that like bridge if you do move? If they move you, like do they help you?
Yes, I've seen the paperwork. I don't know how successful it is. I mean, that was actually my original, when I first was like, I had a plan that I was going to watch them all as they transitioned from their life here to other countries, and I was like, how was I going to do that? So that was my first plan.
Of mine, I have one that moved to Sweden now,
Mm-hmm.
and then one moved to Kampala, but he's back in Nakivale.
Oh, wow. Yeah, no, I have a number of anecdotal stories, of course, through the years, but I don't have any.
But wasn't there about not wanting to grow roots, but how that's fine, but it's still establishing here.
Right, like a sharing with them how the process works, something like that.
That's the barrier.
Right.
Maybe that's a major one.
So in the aim 2 of my K research, which is more quantitative, I have a whole section on migration, like what are your plans, what are your hopes, but I'd love to add also some more about what family do you have here, or I definitely have some about social support and self-efficacy, but I'm actually trying to make it shorter, not longer, but these are good things. This is timely discussion, perfect. Yes. Yeah. I have a section in my qualitative study that I'm doing now about health services and perceptions, and everyone's very positive about it, and I don't know, I think that's partly cultural, in terms of, oh yeah, the services are wonderful, they're perfect. No, there's nothing more that I would want. The staff is so nice, and everyone knows my language, and I know. So where they go. For what? Yeah, that's a good point. That might be more informative. Yeah.
Thanks. You mentioned, well, looking into other areas, help with during a new call or look at that
I have not looked at it yet, but it is definitely built into my AIM 2 and AIM 1. The qualitative part, we have a section around. It's interesting. It's really hard to, when you ask, the qualitative part is not very rich, the data so far, because when we ask, tell me about your, have you ever, the words we use, and I'm not exactly sure exactly what they are right now, but people, whenever we say anything mental health, even depression, they talk right about feeling anxious, and they talk about feeling anxious or sad, but they haven't talked about ever like kind of a clinical necessarily. It's hard to, I don't know, but I do, for AIM 2, I think will be more informative, where I'll put in some actual numeric surveys to try to ask more specifics about sadness or trauma-related experiences. Because I'm not getting enough out of what I wanted in the qualitative part. It's hard, but I think it's a cultural translation or a language translation, but a lot of the questions, they just seem like they're like, oh no, I'm happy, or yeah, sometimes I'm anxious, but it's not very, I don't know. That part is so far. But I would love it if you have any advice for me on the AIM 2. Right now, there's a refugee health screener, like 15 questions. There's the PTSD screener. So there's a number of different tools that I'm trying to sort out. If that's your area, I would love your knowledge. I do have a couple of mental health experts that I'm working with at Harvard, and that's nice as well. But if you have any input, I'll take it. There's a lot of work to be done in the pediatric setting here. It hasn't been done, and partly just when you're starting, it's so hard to get the permission from the adults. But there is a pediatric clinic. There is very active maternal health and HIV testing around antenatal care, and there is a pediatric HIV clinical service, but the research hasn't happened, and I haven't seen it yet. I haven't done it. Well, no, and because they're already enrolled in antenatal care, it's actually like a clinic across the way. But I have thought of something I haven't done but might be very useful is to use the cases as index cases and to be testing family members. We haven't done that yet, but it's something that could be really useful. I think yes, please.
Thought, which is, I mean, as awkward as it is, like to try to find out what's going on with those people who don't blink, I think it'd be worth trying to figure out a strategy. I mean, some work has been pioneered in Uganda, actually, about tracing, defaulter tracing of people who are in HIV care drop out, and the question is, what's their status? think, and there's in this group can summarize the literature too, maybe more recently than I remember, but it seems like it's showing that while we initially assumed that these folks were out of care altogether, a substantial proportion of them are actually, receiving care elsewhere and transfer. So it's not as bad as we initially thought, and maybe that you're the advisor.
Yeah.
And do they have you give them airtime, or
They didn't need airtime to receive it because we were calling, and it was text message for those that could read, and then everyone also got phone calls.
I mean, I was surprised at how many people you have.
Yeah, it's amazing.
Really, it's just again, you need
But they turn it on and off. My project manager, I'll WhatsApp them and they'll write me back the next day. I'm like, I need to hear from
Right,
you.
but it seems like WhatsApp, the message is a little more permanent in there. And you would also have the ability to do voice message.